Welcome, everyone. This is part 4 of the sniper technique webinars. Thank you to Bailey's Medical for sponsoring this webinar and to help us spread the word about the benefits of the sniper technique, which uses the power wire as the main sharp recanalization tool. For me, it's a privilege to be here. My name is Marcelo Guimarães. I'm a professor of surgery and radiology at the Medical University of South Carolina. And we have been using this technique and described this technique back in 2009, 2010. And it is a privilege for me, it's an honor for me to be here with you today. So basically, in part 4, the objectives are to discuss the sniper technique in a different territory. It will be in the treatment of IVC and iliac veins occlusions. And we're going to also share with you some tips and tricks regarding this technique, specifically in this territory. So here's a case of a 63-year-old male with severe bilateral extremities edema and the history of IVC filter placed 3 years before. Here's a good reason why we should remove the filters. Look what happened in this patient. This patient also had dialysis, as you can see in the patient's thigh. There's a AV graft in the patient's right thigh, and you can see the difference in caliber between the right and left legs. And this patient was then sent to us. You can see also there's clot in the iliac veins on the right and on the left side. I'm going to show right there, especially on the right side, a little bit on the left, and the IVC is totally clogged and gone with the filter in place. So basically, and you can see the edema very predominant on the right side, ipsilateral to where the AV fistula is. So what we did in this case, because there's a high risk of reconstructing there, we tried to use, again, conventional technique. We never use a sniper technique without using a conventional technique first. So the problem here, we're not able to advance at all through that chronic clot. So in this case, once we decided to do the sniper technique after we failed using conventional technique, what we did is I was very concerned about not hitting the iliac arteries, the common and external iliac arteries that were kind of on the way. So in order to do that, that's a very good trick that I'd like to share. You can do a pelvic angiogram, get an access transradial or transfemoral, and then you also do a venogram. So you can see here a little distortion of the anatomy, but this is just to align those two images so you can construct one 3D model with both, and then you can have a mapping basically where you need to go. So you can see here venogram from above, venogram from below. Look at the amount of clot that this patient had in the iliac system and occlusion, total occlusion of that segment, as you can see here between the two large clots. The segment was completely gone and non-existent. And of course, the iliac arteries are next to it. So we need to define exactly, like in this yellow line, what path you want to use to connect the two dots without crossing the iliac artery. And that's where the 3D model really helps you to be extremely safe. As you can see, we're very close to the iliac artery. So here we did an iliac, basically a pelvic angiogram, and then we took this cone beam CT and put in the 3D model, use fusion of image, so fusion of the fluoroscopy real time plus the cone beam CT we performed, and then we were able to move in AP, RAO, LAO, we were able to see where we were navigating, and then using the workstation of the angiography equipment, we're able to define this yellow line slice by slice, define that trajectory, and then choose where we wanted to advance the guide wire. It's not necessarily a straight track. Actually, we need to do use a little curve here at the beginning to stay away from the iliac artery. Another important aspect here is to take into account whenever we work with the sniper technique in the retroperitoneum is to take into account where the bowel is and also where the ureters are, especially in this case, the ureter on the right side, in order to avoid damage of that organ. Typically, we are able to see the ureter basically flowing, bringing contrast from the kidney down to the bladder. In case this patient was end-stage renal disease, but is still producing a little bit of urine, But in some cases, there's no way. If the patient is totally dialysis, not producing urine, that can be more challenging. Some people consider using a double J in order to mark where the ureter is. You can also check your trajectory, reviewing that in the diagnostic CT, and see if you're far away, no concerns. But if you're close to the ureter, it's highly advised. I highly advise to use a double J just to mark. And here you can see we're advancing the RF wire towards the snare. I don't recommend for anybody that is starting their career doing a sniper technique to go in one shot. I would suggest to go a few millimeters each time, stop, check an AP, RAO 30 degrees, LAO 30 degrees, and so forth until you get access to the snare. In this case, as you can see, we actually started with the straight power wire, but we changed to a semi-curved power wire. You can see here a curved one in order to get access and to follow that curvature. And you can see here, this two green lines are basically the arteries, and then the straight line was the track that we need to go. So we were very, very close to the iliac arteries. Once we cross, we simply snare out, then becomes a standard technique. Our plan here was to use a double barrel technique again. This is for pre-dilation. You can see two long sheaths through the patient's groin. This is the on the left side, you can see pre-procedure images with an extensive occlusion, large iliac veins dilated with clots inside, but complete occlusion with extensive network through the paraspinal plexus. And then the final picture here, double barrel going around the filter. Some people would say, well, why don't you remove the filter? This filter to me was basically like a rock with calcifications already there. In situations like that, we prefer to leave the filter in place and just go next to it and recanalize in double barrel. And as you can see here, there's no problem to do that. We use two Viator stents. Again, the same concept, the bare part of the Viator, which is above the filter, where the renal veins are, we left that intact. So the flow is still going through from the renal veins into the IVC, and put cover stent, the cover part of the stent all the way down in order to recanalize the this long obstruction. And this is the best part of the chest, a pelvic CT in 6 months showing patency of the stents and the patency of the stents, and the swelling of the patient's leg is gone. So that's the best part of all. Another case of a 63-year-old man with a borderline end-stage renal disease. Patient had a history of multiple central lines for dialysis, recent colitis, abdominal pain. And this patient also came to the hospital with the complaint of abdominal pain, nausea, and vomit. So as you can see, let's go back to the CT for a moment here. This patient had a total occlusion of the IVC. And during the venogram, we can see why this patient was having some abdominal pain. You can see that there is a total occlusion of the basically common iliac veins and IVC, infrarenal IVC. And there's an extensive collateral network through the hypogastric veins, draining back into the rectal veins, back into the superior mesenteric, inferior mesenteric veins, and then to the portal. So it's a very weird drainage that this patient's body ended up finding from the lower extremities. But that's why this patient was having nausea and was having abdominal pain, basically. Having the colitis was all related to venous hypertension. So here's the beginning of the story, beginning of the case. We're getting access from the patient's right side. You can see a total occlusion at the level of the confluence of the iliac vein, external iliac vein, and hypogastric on the right side. We're not able to recanalize this with conventional technique, despite trying hard. You can see a very chronic occlusion with significant network. And eventually, we're able to advance the guide wire, the glide wire, and the catheter all the way up closer to the recanalization. I thought we were going to recanalize this without any sniper technique involved, but we're not able to. We failed. We tried twice to get all the way up, and we're not able to. So at this point, we got stuck, and then we decided to think what to do now, right? I mean, we could use different things, but we have a good experience, and we prefer to use, among all the sharp recanalization techniques, like a colapinto needle or coaxial systems or back end of the glides, of the stiff glide wire, outback device, the Pioneer device that is kind of an outback with an ultrasound at the tip. We definitely prefer to use a sniper technique using the power wire. So here's just some pictures, drawings of what the power wire in this case would be about, similar to what we present in the other cases. We have the snare coming from the IJ approach and the power wire coming from below. Basically, we use a semi-curved catheter to guide the power wire and a 10-millimeter snare on the other side. Again, continuous mode, 2 seconds in active mode. The problem of this case, just to start with, is this patient is a dialysis patient, right? And being a dialysis patient, you can imagine what happened to the patient's chest. There's a complete occlusion of the SVC and brachycephalic veins in the chest. So first of all, what we needed to do here, as you can see, we're having some extravasation there in the chest, but we're able to find the right track using just conventional technique, because I needed to place a 10-millimeter snare in the IVC side of the occlusion, above the renal veins, in order to use as a target. We could also have used, for example, the liver in some situations and get hepatic venous access. That's another alternative, but the occlusion went all the way close to that segment, so we didn't want to go transhepatic. So we try to always prefer to go through the chest if we can. So we're lucky to eventually get down through the occlusion of the chest all the way down to the IVC, as you can see in that picture, documented. We didn't dissect anything. And then here you can see the picture of the IVC at the level of the renal veins with a 10-millimeter snare. And you can see that we are very close using conventional technique, but we are at the same time not on the same place. You can see here we are in parallel. Let me go back. We are kind of in parallel to the stump of the IVC. Another picture showing you we're next to it. And this is very hard to get back in using conventional technique. So that's where, again, the sniper technique can be very useful in order to use as a re-entry tool. Here's an image in AP. Here's an image in RAO. And you can see where the level of the left renal, the right renal vein is. So that stump that we're looking here is not the IVC. That's the dangers that we're looking at if you don't pay attention and if you don't correlate with the diagnostic CT that you ordered during the evaluation of this patient in clinic. That stump was not the IVC. That stump was the right renal vein. And the red marker that we have here, that is where the IVC is. And that's our target place in the 10-millimeter snare. So here you can see the guide wire going through, a cone beam CT showing exactly where we needed to be in relation to the stump. So we have the catheter there and the stump right next to it, but very difficult to see without much contrast. So in this case, because we were I was concerned about not hitting the renal arteries, because we could see that in the diagnostic CT, we were very close to the renal artery, of the right renal artery. So you got access femoral access and did a right renal diagnostic angiogram to understand. And if you look here, there's a pretty nasty, pretty crowded space, right? You have the catheter, the cobra in the right renal artery. We'll have the glide wire that we use to recanalize that segment in the retroperitoneum. And we have our sheath with a 10-millimeter snare all side to side. You can see here in this CT that the renal artery was right next to the IVC. You can see there next to the renal vein as well. So we don't want to hit neither the renal vein, neither the renal artery. And you can see on this angiogram on the side, we did in profile view, you can see how anterior we are here in relation to the renal artery that you have there, the cobra, and how close we were. So again, we have to be meticulous but being detail-oriented, you can do pretty good job. And you can see there the distance was about less than 1 centimeter, but we use the snare as a target again. We kept the Cobra catheter inside the renal vein to give me some sort of a reference. The lateral view is super helpful because here it could show me where the stump was with the snare, 10mm snare. I was able to define a straight line to connect both, while the Cobra catheter was marking for us the right renal artery. And after doing all that, we started with predilation. We had the two sides recanalized. We recanalized one side with the sniper technique, then we came from the other side and connected the dots with the sniper technique as well. Eventually predilated with a 6mm balloon. And then we used the double barrel technique using this the Viator technique, the same one that I described before. In order to do that, again, you need to advance too long, introduce a sheath, in this case, 40 centimeters, because your delivery system needs to be above where the beginning of the stent will be, so you can deliver the self-expandable part of the stent, which is the bare part of the Viator. The Viator, you open up by itself once you unsheath it, and then you drag down to the occlusion site at the level of the renal veins. Once you met resistance, stop, pull back the sheath all the way down to the iliac veins, and then you can deploy bilateral Viator, covered part of the Viator all the way down. And that's what we did. You can see there. So the bare part of the left of the renal veins, not covering the renal veins, not gelling that out. You have to be very careful because in this case, the renal veins were in different sides, different heights, if you will, in the retroperitoneum. In different locations, and we needed to adjust according to the origin of them. And here you can see the double barrel technique with the initial delivery of two Viator side to side, and we used two Venovo stents, 10 by 80 millimeters, to extend all the way down to the stump at the level of the iliac veins in order to obtain a full reconstruction of this. And these are the images pre and post. You can see on the left side, total occlusion, drainage to the retroperitoneum, into the superior mesenteric and inferior mesenteric veins, and here flow directed towards the heart through the recanalized IVC. So in summary, the way we manage all these cases, they're all the same way. We keep the patients under anticoagulation. We don't give anti-aggregation. We are more aggressive, trying to anticoagulate them with Eliquis, preferably. You can also use Lovenox if the patient has history of resistance. That's our favorite. Those are the favorite two medications we use. Always recommend these patients, all of them, to use compression hose as much as possible every day in their life if they can. Compression hose all the way to the level of the knee in order to increase the pressure, increase the flow coming back through the stents. Definitely exercise, physical activity is important. Can be just walk is enough. We strongly believe in that. That's helpful to keep the stents patent. And also we keep these patients in follow-up in clinic. And here's the 18 months follow-up on this patient. Again, he was under anticoagulation. This patient was, there was an impressive venous remodeling. As you can see here, there was a little bit of clot residual here on the left side. You can see in the left common iliac vein next to the stent. We plastered that, did not go away, was not limiting flow. I thought about just leaving anticoagulation. And you can see we're after 18 months of follow-up under anticoagulation, the clots are totally gone. So this is real. The venous remodeling is a real thing. So in summary, the key points of the sniper technique, I would say that it's important to identify, take all the time in the world to identify the correct venous stumps, correlating the CT with the venogram on the table. It's important to check the two stumps and the correlation between the stumps and the RF wire with the 10mm snare in AP, RAO, LAO, or simply use a cone-beam CT in order to check if there's alignment of the RF wire and the snare. I would highly recommend to start this technique. If you never use this technique, is to go slowly. advance the RF wire, the power wire in small millimeters each time, check, and again, AP, RAO, LAO, and make sure that you are still aligned on the same trajectory that you planned initially, and then advance some more, check it again, so forth, until you reach the snare. Consider a cover stent in the IVC segments, but don't jail out the venous confluences. That's why the Viator stent, I think, is important to be used in this scenario. Use the radiofrequency wire, the power wire, only symptomatic patients. There are risks involved with that, so we want to make sure we're careful, and we only use it after we failed conventional technique. It's important to have in review a good pelvic abdominal CT prior to starting these procedures. Get prepared to manage complications such as retroperitoneal bleeding, for example, prevent any injury, for example, of the duodenum that is in the retroperitoneum, duodenal injury of the renal veins, renal artery, and it's important to use the potentially an arteriogram of the abdominal aorta, the renal arteries, in order to see the location of the arteries, as you could see in one of the cases. We always use general anesthesia for these cases, not whenever it's possible, but in every single case, because we really think that in case there's a complication, we want to focus and manage the complication while the general anesthesiology team is resuscitating the patient. So in conclusion, the sniper technique is a good alternative in the recanalization of chronic venous occlusions. In this case, in this webinar number 4, we focus in the IVC and iliac vein segment when standard techniques have failed. I really appreciate your attention, and this technique, it really can, hopefully this technique can be helpful to your patients. I appreciate the opportunity, and thank you to Bailey's Medical.